So yeah, that was, by the way, an excellent talk, Richard. That was really great. I think, the thing I'm left with is that still there are too many clinicians not employing those findings. Using folinic acid, giving mitochondrial support. So I'd love to see that translated more into clinical care. I feel like my talk will pale in comparison to everything Richard's done, but I want to give you a sense. The basic purpose of this talk is to really give you a sense that EEG is a very old tool which is ready for a rebirth, and that rebirth will happen through signal processing. And that's the summary, and it will have many applications to autism. So if you want to turn your brain off, you can, but, but just to give you a sense, I want to give you a sense of how old this is. So, EEG, the initial development goes back into the 1800s by Richard Gaitanis, and it was not even felt, at the time of his death in 1926, it wasn't even felt to be that important an accomplishment. It wasn't even mentioned in his obituary at that time, because it really hadn't made it into clinical care at that point. And this is sort of one of the early devices that was used. The galvanometer was initially used to measure heart signal, EKG. And once the EKG came out, so once we were able to do an electrocardiogram, it really led to this idea that maybe we could look at brain signal too. So Hans Berger is actually credited with really bringing EEG to clinical care, but again, giving you a sense of how old we're talking, 1924. So here we are 99 years later, right? And we're still using this same tool. The first patient reported in 1929, papers in German, but these are the signals. This was, at that time, they didn't really have amplifiers, so this was a patient who had a skull defect, and it allowed Hans Berger to record those signals from the patient, because at that time, to really measure through the skull, you needed amplifiers to do that, and that hadn't yet come about. Hans Berger has a little bit of a conflicting past, though, so apparently he was a Nazi supporter. Initially there were reports that he wasn't. There was a recent abstract demonstrating that he actually was directly supporting the SS. He also signed off on at that time they would use physicians to sign off on basically murdering patients who had developmental disabilities, and he was apparently responsible for having done so. So it's a very conflicting kind of past here. But this is an example of what that early EEG looks like. In the US, though, this is where it really picks up, is that, and this is where I like how history repeats itself. So the story of Gibbs and Grass is great, because what happened is Gibbs was a neurologist who wanted to figure out how are we going to use this new tool. So this is the 1930s. So he had Grass working in his lab. Grass was an MIT student, an engineering student. Gibbs was going off to Europe for the summer, and back then, of course, in the 30s, when you go to Europe for the summer, there's no email, no cell phones, none of that. He gives this assignment to Grass. He says, I want to build an EEG machine. Comes back at the end of the summer. Grass is working on this in his family garage in Quincy, Mass, with his brother. He comes back, and he's got this beautiful wood, like nice mahogany, looks like an old stereo set. And this was the Grass 1 EEG machine. And it was a working example, and it was able to, from that, they were able to record really all the clinical tools that we use today. So what we use clinically today, a lot of this really dates itself to the 30s. So we're looking at, again, 80, 90-year-old technology, and that's what we are using. But they published the same sort of findings that we use clinically all the time. They published all the various seizure patterns. I could read their papers from back then, and it looks exactly like the atlas I learned on, when I was learning EEG. So where things changed, EEG was really it was one of the only tools we had in neurology for a long time. But then in the 70s, CT scan comes along, and then later MRI. And that really replaced EEG for this purpose of looking for structural abnormalities. And so now EEG is primarily used, in today's world, for epilepsy evaluation and for evaluation of people who have impaired consciousness, stupor or coma. It doesn't have a lot of other clinical utility directly anymore. But the biggest problem is we are looking at EEG the same way they did in the 30s, right? So we're looking at raw waveforms. And the challenge there is that when you look at how sensitive is this tool, and those sensitivities really vary depending on the studies, In patients with, say, known epilepsy, when you're looking at just raw waveforms, the epileptologist is really limited in how accurately they can say this person does or doesn't have epilepsy. So for epilepsy, only about 37% sensitive in one paper. In other papers, it's a little better. It gets about 50%. But if this was a COVID test, for example, and you had 50% sensitivity, I don't think anybody would use it, right? Or maybe we shouldn't COVID test anyway. We forget about it. Anyway, but that's a separate topic. But, at best, you're looking around the 60% range for sensitivity. And that's because we're looking at raw waveform. And so it remains really one of the primary tools that we have, but we have we have reader variability between the same reader. I may look at an EEG on Tuesday and then look at the same one on Friday and give you a different interpretation because maybe I wasn't fully focused, I don't know. And then the same thing, if I look at a study and my colleague looks at a study, we have slightly different interpretation. It's very, very subjective still. In autism, though, we don't really have a lot of utility for EEG in terms of evaluating or subtyping patients with autism yet. The only area that we really may utilize it is this issue of subclinical electrographic abnormalities. And what we're talking about is some kids with autism, a fair percentage, will have EEG abnormalities that look very epileptic. So specifically, spike wave discharges can occur in a fairly high percentage. That exact percentage varies widely depending on what study you look at. So, I list here, you can see it between 4 and 86% of patients. I mean, it sounds laughable. But when you look at, if you compile all the different studies, that middle section here is, the percentage of patients who have these subclinical electrographic abnormalities. And each study really varies quite a bit. You have an 8%, you have a 48%. Here, I mean, this is like interesting. You give some findings like higher incidence and regression, things like that. I thought this one made no sense. Like here, tall stature was associated with, that makes no sense, with subclinical electrographic abnormalities. So you get really widely varied data on this, but we know that that's common enough that it's still worth evaluating. I think the question that we have with EEG now, though, is what do you do with that information? Probably the best study of all those studies I showed is this one large retrospective study that showed about 60% of patients did have these abnormalities, and mostly in sleep, so it really emphasized the need for a sleep EEG. But again, the question is, what do you do with it? I mean, you find that these abnormalities exist. Do you treat them or not treat them? The data there are also imperfect. There have been some suggestions that treating may improve developmental outcome, but it's you can see there's a wide variation in terms of how we understand these abnormalities. Clearly, we need to improve this technology, though. We're dealing still with 100-year-old technology. We're still clinically reading raw waveforms, which is just bizarre in this day and age that we do that. And that's why it was around Y2K, it was around 2000 when digital EEG really started to take hold. So I did my EEG fellowship in 2000. So I did my EEG fellowship reading paper, and we were right in that transition time. So a couple of years after me, everybody was digital. Everyone before me was on paper. I read on paper. My left hand got really tired. You would have to flip, but there was a certain beauty to it too. I mean, it was, what I read on was no different than what was being done in the 30s, for example. And I was reading on old grass machines. It was just a newer version of the same. But with digital, things have changed a lot. What's interesting, though, is there's a sort of perseveration that neurologists have done. When we got digital EEG, we basically set it up to read exactly the way we read it on paper. So we still look at raw waveforms. We haven't really asked the question, whoops, and I just fast forwarded. We haven't asked the question, what do we do with that digital signal? And I'll give you a sense of what we can do. So rather than reading, I apologize because I hit some button that just moved me really far forward. But to give you a sense of what you can do with the digital, the biggest thing I think that's going to come is going to be signal processing. And there are a lot of ways to do that. You can look at Fourier transform, wavelets, things like entropy, and ultimately all those different signal characteristics can be used for a classification system. You could develop a classifier that using things like machine learning to help identify, like, yes, this patient has autism, or yes, this patient has epilepsy, without looking at the actual raw waveform. That's my theory. one of the ways I wanted to look at that, I'll skip over all the intricacies of these different measures, but these are some of the measures that I've looked at on EEG. But one of the ways, one of the things I think has been interesting is to really look at what we call normal EEGs. Because an epileptologist may look at an EEG and say, hey, this looks normal, but the patient actually has epilepsy. So the question is, was it really normal? And I've tried to ask that in a few different ways. So using wavelet, and I won't get into details, but I was kind of interested initially in surgical cases. Most kids don't go for surgery, but this is one of my surgical cases where there was an epileptic region here, an epileptic region here, and then you have a lot of kind of normal healthy areas. And when you actually capture a seizure, you can see the seizure pretty, even if you don't know EEG, you can kind of see there's some differences here on these lines that you don't see on the other lines. But if you're looking when there's not a seizure, you just see a bunch of squiggles on a page. It's really hard to tell. Like if I looked at this, I couldn't tell you exactly where the seizures are. So I was kind of curious, if I take these clean pages, can a computer distinguish by doing signal processing? And it turns out you can when you look at the seizure foci and you compare two seizure foci versus, and these are non-adjacent foci, by the way. They're not simply like adjacent leads. They're separated by distance, but they're both involved in the onset of the epilepsy. And if you compare them to areas that are not related to seizures, you can actually see statistically significant differences using a tool like wavelet transform. And so then I got a little curious, well, what about surface EEG, right? So this kid, I mean, this is actually the kind of EEG most people do. Most people don't get invasive brain surgery. And I'll kind of jump ahead, but with wavelet, like this is an autocorrelation, but this is an example of what we can show with an autocorrelation where these are all normal EEGs, every one of these normal. We didn't capture sleep. What I'm doing is I'm taking just segments of pages without any epileptic discharges that nobody would call abnormal. But even then, you can see the normal, like doing an autocorrelation, the normal is very different than a patient with benign Rolandic epilepsy, is very different than generalized epilepsy. You can kind of tell from using these tools who actually has epilepsy, who doesn't. And then other tools, like I'll skip over the methods because we don't have a lot of time, but we tried to develop a classifier to look at this, looking at entropy as a tool. And one thing that's interesting with entropy, one would think, entropy is really, you think of it as chaos. So one would think you don't want chaos, but actually a healthy brain has higher entropy generally. For things like Alzheimer's disease, that's been shown. Healthier brains have more entropy, more chaos. Unhealthy brains, lower entropy. And these are, again, completely normal EEGs. So the way we did this study is we looked at kids who came in with a single seizure and a normal EEG. And then we followed them, and kids, 30% of those kids had a subsequent seizure. So 30% basically had epilepsy, but every one of these initial EEGs was normal. And yet when you look at entropy, the red is kids who never had another seizure, and the blue are the kids who had epilepsy. Very consistently, the kids who did not have epilepsy always had higher entropy than the kids who had epilepsy. Not statistically significant amongst groups, however, there were some outliers who were very low on entropy, and when you were below a certain value, 100% of those kids had epilepsy. And so, again, from a normal EEG. So it's kind of suggesting we're missing something. And that's for epilepsy, but I'll give you one sense, we can't do it. In autism, you have a particular challenge, which is that a lot of kids don't particularly enjoy the experience of getting an EEG. And so we need to think about how can we get cleaner signal? If you have a kid who's moving a lot during the study, can I avoid that movement artifact? So one way to do that is to think about how I actually capture the data. So if you capture a lot of garbage, if you're capturing just muscle and movement artifact, you're not going to be able to make much heads or tails out of the data. It doesn't matter how much I signal process it, it's going to still be garbage. So working with an engineer who developed a new lead design where it's a series of concentric rings. So regular EEG is just the outside ring, and here we have 3 rings, and that allows us actually to subtract out all that muscle and movement artifact. And this is an example of what we've shown with that. So using a regular EEG, you basically get a lot of this really jagged stuff, and that's all from movement and muscle. And then this is what we would see with the concentric ring. But more importantly than just the reduction in artifact is actually you start to get some interesting things that you don't see with regular leads. So you actually can start to see what are called high frequency oscillations. You can see these really high frequencies. These are around 80 hertz or so. Normally in EEG, when you see a signal that fast, it's typically muscle because the skull's filtering most of that. But using this type of lead design, we can actually appreciate that. And this is right before a seizure. So here's where the seizure starts, where you can appreciate it. This is the onset of a generalized seizure, and this is a spectral analysis of it. The regular EEG shows the seizure. What the regular EEG doesn't show are these high frequency oscillations before the seizure. And so that gives you, and this is what they look like if you look at them up close. This is the regular EEG, and this is with a tripolar concentric ring electrode. And it allows us to actually see these high frequency oscillations before the seizure even begins. And this is an example. This is an example of what that high frequency would look like, which you totally miss on the routine EEG. So if you improve hardware and software together, I guess that's sort of the thesis. Same tool, basically it's EEG, but it does require, a reevaluation of how we're using it. So lots of possibilities here. If you can get improved hardware and software together with this 100-year-old technology, right now we're using this technology primarily for epilepsy and stupor coma. That's it. But what if, again, thinking about the fact that normal EEGs, you can begin to separate patients. You can begin to see features that you don't appreciate visually. Perhaps we could start to look at things like dementia or concussion, or more importantly to this conference, autism. And some of that work has happened. So one thing that's really interesting in autism is you do tend to see higher, this is like an interesting difference between autism and patients with and without. So in patients without, this is a power spectrum, but when you look at the power spectrum, patients with autism tend to cluster in the lower and the higher frequencies. You get a lot more power in delta bands, which are slower frequencies, and beta, which is a much higher frequency. As opposed to patients without autism, they tend to cluster more in that alpha band, which is like more of an intermediate band. And there likely are direct neuronal mechanisms for seeing that finding, but that's just an example of what you can begin to evaluate with signal processing. And so that U-shaped curve is felt to relate really to GABA, like alterations of GABA functioning. Perhaps GABA interneurons might play a role. The other things that are really interesting, coherence is very much affected in autism, and that's something too you can see with signal processing. Coherence really has to do with how connected are different regions. And in patients with autism, you tend to get decreased, that connection between different brain regions tends to occur both between hemisphere as well as between regions within the same hemisphere when you compare patients with autism to patients without. And so I think those are important things to think about. And how are we going to use this going forward? So one thing is to think about, can we use these tools to more correctly identify subtypes? And that might be really important for setting up clinical trials, for example. So Dr. Fry presented differences in biomarkers related to patients with regression. This might be another way to look at patients with regression versus those without. Can you look at who's a medication responder? Maybe rather than doing trial and error, perhaps we can begin to identify who's going to be a treatment responder beforehand. Or if you're just starting a med, you could do a before and after EEG and assess if somebody is a treatment responder before waiting, say, 6 months to feel more confident. And then I think what would be really interesting, we're not quite there yet, but there's potential to develop closed loop systems. You can think about, as we get into an age where we're using transcranial magnetic stim or even transcranial electrical stim, and if you wanted to up or down regulate certain regions, maybe using these EEG data will help us find those targets more effectively. So there's potential there too. We do that in epilepsy, but I think there's a possible role here as well. So with that, I'll leave you with beautiful downtown Providence in the winter. So thanks. I'm open to any questions. Yeah.